Hello, everyone, and welcome. I know folks are just starting to log on, and so I'll prolong my intro just a little extra. Welcome to day 2 of IH Research Week 2022. My name is Kim Peek, and I'll be your guide for today. I'd like to start by acknowledging that I'm located in the Okanagan as an uninvited guest on the traditional, ancestral, and unceded territory of the Syilx people. We welcome you to share the names of the traditional lands that you're gathered on today in the chat box. If you do not know the names of the lands, please visit the website native-land.ca. We'll ensure to share the link in the chat box also. IH Research Week 2022 is hosted by the IH Research Department in partnership with the BC Support Unit Interior Centre. Presentations this week will include focus on 3 main areas, either collectively or individually, including community, health, and research. Thank you to everyone that has helped shape this week and also to everyone that is here today. So a few housekeeping items of note that we want to share is we have the week set up in webinar mode, and we'll be recording with the intent of sharing at a later date. As a registered attendee, you'll receive the recording link when it's available. Please ensure to use the chat box to connect with speakers anytime. And as well, know that reactions can be viewed by both the panelists and attendees. If you're like me and you're like, what is a reaction? On the bottom of your screen, it has the little smiley face, and these are the emojis like the thumbs up or the hearts. If at any point you need to take a stretch or a break, please do so. Ensure to take good care of yourself. So it's a pleasure and an honor today to introduce our first speaker, Marie McClelland, registered nurse and clinical research coordinator for Interior Health. Her presentation is titled, A Day in the Life of a Clinical Research Coordinator. Take it away, Marie.
Thank you very much, Kim. I would also like to respectfully acknowledge that I live in the unceded territories of the Syilx people here in Kelowna. I'd like to share my screen now, please. Is everyone able to see the screen okay?
Not yet, Marie.
Okay, I apologize. Are we there now?
Perfect.
Okay, thanks. Okay. So this is an attempt to share with you what it's like to be a clinical research coordinator. I've taken a lot of different experiences from not only myself, but some of my colleagues, and sort of made a montage. So who is a CRC? We're a diverse, multi-talented group of professionals from a variety of disciplines, and we're trained to conduct clinical research involving human participants. Some of us are nurses, some of us are non-medical. The training that we receive is quite extensive. First and foremost, most important one that we do get certification for is through Health Canada. This is the Tri-Council Policy Statement, consisting of 8 modules regarding ethical conduct of research involving humans. Good Clinical Practices is, of course, a 12-module program that discusses good clinical practice as it relates to clinical trials of both drugs, biologics, as well as devices. Health Canada Division 5. This deals specifically with drugs for clinical trials involving humans and is governed by the Food and Drugs Act and the Food and Drug Regulations, governing the sale and importation of drugs for use in human clinical trials in Canada. And transportation of dangerous goods. We also require this certification because for some of our studies, we draw what's called central labs. We draw blood or we collect other human specimens, and then they have to be transported to a central lab or to this a site that the sponsor has designated. And there's a lot of regulation around the packaging and transporting of these samples. And there's still more training. So human subject research biomedical, it's 9 modules. There's multiple other training modules that refer to privacy, and this is over and above the normal level of privacy training that you have to have. There's also protecting human research participants, responsible conduct of research, and then there's many I-learns that are required by Interior Health. There's also Interior Health Clinical Research Standard Operating Procedures for Clinical Research. There's 26 documents that we must be familiar with, and if we can't immediately state what it pertains to, we have to at least know where to find it. Research Ethics Board and Regulatory, there's also multiple documents and training. We have to understand the clinical trials process, and there's a lot more. Many training certifications have to be renewed on a regular basis, many of them annually, and training requirements can vary with each individual study. And I believe we are currently running between 15 and 18 studies within Interior Health for clinical research. What does a CRC do? This presentation represents a typical day, so one day based on actual experiences of CRCs in our department. Every day is different. It can include meetings, patient appointments, data collection from Meditech, which is the electronic medical record, and paper charts, data entry, mixing and administration of investigative product, which is usually medications or drugs, and that's just naming a few. Our hours of work are flexible. They absolutely have to be, because it depends on the requirement of specific studies, as you'll see in the next few slides. So this is me rolling out of bed Monday morning at 500 hours, so 5 a.m. It's hard to get up, but I have to mix the deposition study drug for a patient who's scheduled for the OR at 7 o'clock. So at 5:15, I guzzle down a huge cup of coffee and try and scarf down a muffin as well, because I need fuel. Have a shower, apply my face because I don't look great without a little bit. Dress in cycling gear, and I pack a change of clothes for work. And then I mix a thermos of my favorite chai latte. On the way out the door, I kiss my cat Seamus O'Tail goodbye, and I pat my husband on the head, and I'm probably not completely awake because I mixed those up. And it takes me approximately 20 minutes to bike to work. So I arrive here at Kelowna General Clinical Research Department, quickly get changed. I meet with Alyssa, who is the lead coordinator for the deposition study. So this study is comparing intravenous tranexamic acid versus intrathoracic TXA, tranexamic acid, to determine which route of administration is most effective in reducing bleeding when patients undergo open heart surgery. So this is an approved drug that it encourages clotting and reduces blood loss. But we're looking at which is the most effective way to administer it for these patients. So Alyssa randomizes the patient on the computer online and secures an email that is sent to me with the patient's drug allocation. Alyssa remains blinded. She doesn't know which drug allocation the patient gets. Only I will know that. And that is to avoid any bias when Alyssa collects the patient's post-operative data. By removing bias, we can ensure that we have really clean data that isn't going to lean towards one therapy or the other. At 6:10, I print off the study drug mixing checklist, which is shown here in the box to the right. And it tells me which kit is going to have the active study drug, and which is going to have the placebo, which is normal saline. The staff in the operating room are also blinded. Nobody knows which arm this patient has gone to except myself. I then hand off the assembled study drug kit to Alyssa. It takes approximately 20 to 30 minutes to mix this. You have to be very, very meticulous in how you do it and make sure you're putting the right label on the right syringe. I then have to file the study documents and lock everything back up. Only those nurses in our department who are mixing drug have access to the key that unlocks the cupboard where study drug and the patient log is kept, which tells us which patient received which treatment. Now that I'm finished up with the deposition study, I go back to my computer and at 06:55, so we're not even at 7 o'clock in the morning, and I start going through my emails. I was on call this last weekend, and I was notified by the Vancouver office that our Frontier Stroke Study had a patient enrolled. Paramedics enroll these patients before they get to the hospital when they're at the scene of someone who is determined to be having a stroke. This study is investigating the efficacy and safety of a neuroprotective drug called narinotide versus placebo for acute ischemic stroke. The theory behind it is if we can protect the brain for a period of time and delay the effects of the stroke, that gives us more time to do definitive treatments that can help us to preserve brain tissue. I have about 24 hours, plus or minus 6 hours from the time of admission to the emergency department of the patient to complete the first visit and the assessments. So I looked the patient up in Meditech. The time of arrival was 11:40 hours yesterday. So the window for my follow-up is from 5:40 a.m. to 17:40 or 5:40 p.m. today. The patient received TPA, which is a clot busting drug or dissolves the clot. And often when patients have strokes, they can tell on the imaging that the clot is probably going to be too big for just the clot dissolving drug to effectively dissolve it to restore circulation to that area of the brain. So we will also often take patients for endovascular therapy, so EVT, where we go in and with a catheter through a large vessel in the groin, and we thread that catheter up to the brain and remove the clot. This patient has had a good outcome. He's doing very well, but he's in ICU awaiting reassessment by neurology. All of our patients, if they receive thrombolytic therapy like TPA or TNK, or if they go for endovascular therapy, they are monitored in ICU for 24 hours. So they need much more intense nursing care than they will get on a general unit. The next thing I do before I go and see this patient is get in touch with his wife. Frontier study uses deferral of consent. So the paramedics will inform the family that they are want to put the patient in the study if there's somebody there. But they don't go into a long, detailed explanation of the study because you're losing 2 million brain cells a minute when you're having a stroke. So you don't have time to take 15 to 30 minutes or longer to explain the study and get consent. So we use deferral of consent, and then it's up to the clinical research coordinator to follow up with the patient and the family to go into more detail about the study and obtain written consent for continued participation in the study. So at 7:30, I call her, I identify myself and why I'm calling, and we agree to meet in ICU at noon. She also provides me with her cell and gives verbal consent for me to review his records. At 7:45, after the call is complete, I document this call in the progress notes of the patient's case report form that I have already started. This is the Frontier checklist that I put together before we started the study in 2018. And this is just the baseline and what happens after the patient arrives in the emergency department. I review this and I head over to the emergency department where we have a special drop box. The paramedics will put the empty study drug vials in this drop box. I collect those, and that is used to close the loop so that we know that patient got what they were supposed to get, and then we log that in. At 8:15, as I'm leaving the emergency department, I encounter the stroke nurse and speak with him. He was on yesterday, so he knows this patient quite well. He updates me on the patient's symptoms and the patient's progress. Since I have to do a full NIHSS, which is the National Institutes of Health Stroke Scale, I have to do it for this study. We agree that I will do it for him, and I will enter it in the patient's chart. And that's just one less assessment he has to do. And we're not both doing the same assessment on the same day on the patient, because it really doesn't achieve too much to do that. At 8:30, I head back to the office to start going through my checklist and completing all of the items on this checklist. So I start the source data collection for the Frontier patient, and that means going into the Meditech and printing off documents. Pertinent documents have to be printed for later signature by the qualified investigator, Dr. Takash. And my computer crashes, and this cat howling is exactly what I feel like. I respond accordingly whenever my computer goes down. So by 9:30, after I get my computer working again, I get the checklist all updated. I've printed off the required reports that Dr. Takash has to sign off on for the study. He's acknowledging that the patient has been appropriately enrolled in the study, that he meets the inclusion/exclusion criteria, and that the appropriate tests have been done. I put all of these documents into the patient's case report form binder. 9:35, I called ICU. I speak with the patient's primary nurse and request that she call me when the patient returns from this 24-hour CT scan. So on all of our stroke patients, they receive a 24-hour CT scan to see how the stroke has evolved and to make sure that there's no other untoward findings on the CT scan. I also tell this nurse that I will be meeting with the patient and his wife regarding his participation in the Frontier study. So while I'm working away, I get a call from the wife of another Frontier patient at 9:40. And this is to tell me that her husband had been admitted for gallbladder surgery about a week ago and had surgery and is now at home recovering. This is a serious adverse event. Patient is still in follow-up in the study, and a serious adverse event is an adverse event that meets any of the following criteria. So, life-threatening, a medical procedure to prevent disability or death, requires hospitalization or prolongation of hospitalization, or an important medical event. So this patient's event meets 3 of the above criteria. It was an important medical event, it required hospitalization, and he had a medical procedure, so he had surgery. SAEs must be reported within 24 hours of the CRC's knowledge of the event. So even though it happened last week, I just found out about it. So I have until 9:40 tomorrow morning to report it to various people. So this is the SAE reporting form for this study that varies a little bit from study to study, but they all follow the same criteria. It takes a lot of time. You have to go into the patient's chart. So at 9:45, I put an urgent request through to the health records department and say, please pull this patient's chart And I also start reviewing his record in Meditech. At 9:50, I text Dr. Alex Takash and ask for a meeting for this afternoon because he needs to review and sign off on this SAE before I can submit it. And it needs to be submitted to the Regional Ethics Board, REB, to the sponsor, and to the study monitor. At 10:05, Dr. Takash phones me back. He says, yeah, sure, I can meet you this afternoon. But then he enthusiastically tells me that he has emailed me a protocol for a new study that he wants to do. So a little bit more work just landed on my desk. So around 10 after 10, I head over to Health Records. And what's really great about our office is it is next door to Health Records. And we have a really great relationship with them. They're very helpful and they have pulled my chart. I can't take the chart out of Health Records though. Only under very, very special circumstances can charts be removed from Health Records. And it's a big deal. So I have to stay in Health Records to go through these forms. While I'm over there at 10:20, Colleen Adderley, who is my manager, calls me to say that she had been CC'd on an email from Dr. Takash regarding a new stroke study. So this is the same one he had mentioned to me a little earlier. She asks me to complete the feasibility form and submit it after I've had a chance to review the protocol. The sponsor wants it within the next 2 days. And review of a protocol can be quite lengthy, and reviewing the protocol and completing the feasibility form can take several hours. So a feasibility form is a form that we fill out to say, yes, we can meet the requirements for conducting the study at our site. So by the time I'm finished gathering my information in Health Records, it's getting close to time for our Monday morning huddle in our clinical research department. So at 10:30, I return to the office and we all sit down and we start to discuss our week's workload, who has got some spare time and might be able to help out, who's drowning, that sort of thing. So we all try and work together so that nobody's feeling like they are overwhelmed. I do have a patient scheduled for this afternoon, and Camille graciously agrees to do the 90-day follow-up on this patient for me. She's also signed on to the study with me, and that gives me more time to work on this new frontier enrollment and to complete my SAE. And maybe if I get time, work on the protocol review for the new study. So we wrap up our meeting. Sage Runner and I have a little discussion about the Calgary Flames chances for the Cup this year. And we trash talk the other teams. Go Flames. And my apologies to all of the other teams and anybody who might support them, but Flames are going to do it this year. At 11 o'clock, I start filling in the serious adverse event form and preparing it for Dr. Takash. And it's getting close to time to go see our newest frontier patient. This isn't an actual photo of my patient. I took this off the internet. The ICU nurse calls me to say he's back from his 24-hour CT scan. I do a quick review of the radiologist's report of that CT scan, and I print that off because Dr. Takash is going to have to sign it as well. 12 o'clock, I get to ICU and I find his wife has arrived. They very happily tell me that he's doing so well, he might be discharged tomorrow. So that puts a little bit of pressure on me to get the consent signed and get my assessments all lined up. It takes about 40 minutes. It can take up to an hour or more to explain a study to the patient and review the informed consent form with them. We also, in cases like this where there's not intense urgency to get consent, we offer the patient time to review the consent form and talk to family about it, whomever they wish, actually. He says he really would like to continue with this study, but they want to review it with their family. And so I leave them with a copy, and we agree that we're going to meet tomorrow. I then asked him if it's okay if we go ahead and do the 24-hour assessment, and he says, sure, that's no problem. He gives me verbal consent when he says that. And he also gives me permission for continued review of his chart. So between 12:55 and 13:05, about 10 minutes, I complete the National Institutes of Health Stroke Scale. It's a neurological assessment that is recognized internationally and is the gold standard for assessing patients with stroke symptoms. This gorgeous little raccoon is demonstrating his equal limb strength, which is one of the criteria things we test for on the NIHSS. I also go over with this patient a review of his medical history, any medications he might be taking. I look at his ECG, his labs that were done in the emergency and this morning. I look at any imaging, CT scan, echocardiogram, all of that sort of thing. And I chart my visit in the patient's chart in ICU. And this is so that anybody who's caring for him knows that he's in a research study. If they have any questions about it, I leave my contact information there. At 10 to 2, at 13:50, the patient, his wife, and I agreed that we're going to meet tomorrow morning, and we will go over the consent again. And if he is in favor, then he will sign the consent, which he gets assigned. He gets one of the signed copies. I keep the original, and I also let them have my business card so they know how to get a hold of me if they have any questions. So it's 2 o'clock, and I go back to the office. I haven't had lunch yet, so I grab a bowl of soup, and of course, I eat it at my desk. Sometimes we're pretty bad for not taking a formal lunch hour, but this is a busy day, and so I'm eating lunch at my desk. At 14:10 or 10 after 2, I complete this SAE and assemble the other documents for Dr. Takash's review and signature. At 20 to 3, I open the email from him and the attachment and start going through the protocol synopsis that the sponsor has sent to us. It looks like a really interesting study, but I don't want us to commit to it until we do a full review. And there may be a few things that aren't in the synopsis that would be in the full protocol that might raise flags for us. So at 5 to 3, the doorbell rings and Dr. Takash comes in. He reviews the SAE report, sits down at my computer and makes a few changes to the report, and then we print it so he can sign off on it. He signs all of the other documents, and then we start to discuss this new study. I pull up the feasibility checklist, we go through it, and we think that most likely we would be able to do this study. So when I have a little bit more time and before the deadline in 2 days, I will complete this, have a quick discussion with Colleen as well, and then submit it. 15:25, my desk is just a total disaster. And so I start filing documents, locking up patient binders, trying to tidy up. All information pertaining to studies, including patient documents, regulatory documents, must be locked away. Health Canada requirements are that they must be in a locked office, in a locked room, in a locked cabinet. And it's very important. We have to protect our patients' privacy, but we also have to protect our sponsors' regulatory and important documents, because it's not public knowledge yet. These are clinical trials. So I'm almost done for the day. 3:30, I check my calendar. add in some meetings, appointments, create a to-do list, because if I don't write stuff down, I'm not going to remember to do it tomorrow. And it includes the follow-up with the Frontier patient for the consent, submission and filing of the SAE to the ethics sponsor and to the study monitor. I have to complete and submit the feasibility form for that new study. Talk to Colleen so she knows that we're going ahead with this. And if we are selected as a site, then I will give her the information she needs to start the contract negotiations. And by 3:45, I'm changing into my cycling gear and getting ready to head home. That's my day. And I'll open it up to questions if anybody has any questions.
I love that so much, Marie. Thank you so much. My favorite part of your whole presentation has been your amazing pictures that you've included, which have made it like so much more engaging, right? Like it's just, anyways, I appreciate that so much. So
Well, thank you.
For attendees, feel free to enter questions into the chat, and I'd be happy to facilitate the moderation of them over. I have one to start with, Marie, which is, can you give your opinion on the importance of relationship building with your role?
If you aren't able to build a relationship, then you're sunk. So that's one of the most important things about this job. You have to be able to collaborate with different departments within the hospital, different departments within interior health. You have to be able to have open and transparent conversations with your patients. You know, we can't come across like we've got a secret or that, you know, and I have a lot of patients say to me, oh, so you want me to be a guinea pig? And I say, no, we've already completed our studies on the guinea pigs. Now we're working on humans. And I mean, that's one of the reasons why we have to go through the consent form with them. We have to show to them that we have an important question to be answered that may improve patient care and patient outcomes for a certain disease process. And they have to also know that it's completely voluntary and consent is always ongoing. If they consent today and then they change their mind next week, all they have to do is let us know and, you know, pick up the phone and say, I don't want to take part anymore. And, you know, we don't question that. That is their decision. And I've actually had very, very few patients. I've been doing this for 20 years, and I've had very, very few patients withdraw from a study. Sometimes they do, and that's their prerogative. But you know, I've been very fortunate. I was at a convention this last week, and one of my colleagues who I used to work with in Calgary told me about a patient that I had enrolled in a study where we did 10-year follow-ups on these patients. So every 3 months we had contact with them for 10 years. And so you really do build a strong relationship with them. And this one fellow completed his 10-year visit after I had left and come back to Kelowna. And my colleague told me that he had been so impressed and so happy to be part of the trial and enjoyed the benefits that he got out of being part of the trial, that he made a large donation to the Calgary Stroke Program as a result of being part of a clinical research study. And, you know, the benefits to being in a clinical research study, we can't guarantee that there's going to be a benefit to you, but you do get more personalized attention. And sometimes the clinical research coordinator can help a patient navigate the healthcare system. If they call and they say they're having a problem and they describe symptoms that are a little concerning or even alarming, then we can advise them on what to do so they can get faster treatment. So, you know, the relationship is, I can't emphasize how important it is. It is very, very important.
And you can see that you could see that evidence in the way that you spoke with your presentation and for the people that were included in it. So we have a question that's come live, which is how you got started as a clinical research coordinator. What drew you to this job and role?
I kind of fell into it serendipitously. I've been a critical care nurse since 1975. And in 2002, I've been working at Foothills Emergency Department for about 14 years. And I developed chronic bursitis in both hips, and my GP said, you got to get off your feet. And so I started looking around for other opportunities, and the Calgary Stroke Program was advertising for a clinical research coordinator to do a chart review. And I applied for the job, and I don't know why, but I was the only applicant, and got the job, but it meant going out of scope. And so I negotiated with him. I said, if I do this 1-year contract, could you please try and make a position for me at the end of the contract, because I'm leaving everything, my job security, all the rest of it. They were wonderful. And once I got into it, I just loved it. I mean, the learning curve was near vertical, but it was so interesting and great people to work with. The more I learned, the more I wanted to learn. And if that hasn't changed in 20 years, I just love this.
Unmuting myself is helpful. That's awesome, Marie. So the next question, and I'm not sure if you'll be able to answer, how many clinical research coordinators might there be in BC from time to time?
I don't know. I know there's a lot more down at the coast than there are here. So I couldn't give you a number.
That's fair. That's fair.
Yeah.
I wouldn't know offhand either, but I think
I would say there's at least 50 plus, probably closer to 100, but I don't know for sure. Don't forget, there's also clinical trials being run through BC Cancer and other agencies. So, not just our clinical trials.
Yeah, well, good inclusion of that too. And I have another question, which is that how because you've mentioned 20 plus years of being in this role, so how have you seen the role evolve and change over time? I'm imagining there's been quite a bit of changes.
Yeah, there's been a huge change. What I've noticed is, particularly in the last decade, our regulatory has changed, in that we're one of the most regulated professions and businesses, if you wanted to call it a business, that I've ever seen. And it's necessary because we're conducting research on humans. The International Council on Harmonizations, which is the international governing body, they also regulate other types of research. But over the years, it's become more and more apparent that different countries have different approaches to conducting clinical research. So that's why they have brought in more stringent regulatory guidelines. Canada is a leader, actually, because we have adopted those guidelines and put it into practice, and put it into such we've structured it in such a way that other countries are looking at what we have done and adapting that model. So nice to know that we're doing so well.
Definitely. And next question up, do you have any tips on keeping organized with your studies?
Prioritization. So I think being able to switch gears really quickly, recognize what's a priority and what can wait. And if you've got too many big priorities hanging fire, reach out to one of your colleagues. I have a saying, and my colleagues will laugh at me when I say this, but I go back to when I used to work in emergencies. So check your pulse. If everybody has a pulse, everybody's breathing, everybody's protecting their own airway, and there's no bone sticking through the skin, it's probably not an emergency. So you've got time to figure out what your next step should be. And you know, and not sort of rush off and because I've done this before, rush off thinking that I'm solving a problem and then realizing that I missed a critical step. Now I have to go back and do it all over again the right way. So organization is just, I think, recognizing priorities. And every day I sit down with my to-do list and figure out what's important, what's been taken care of, that sort of thing.
I like that, the stay calm and then carry on.
That's it.
Yep. And also make sure that you apply your oxygen mask first before others, right? It's good advice, very good advice. I really I loved your mention of the to-do list for the next day. So I'm a huge advocate for that too, especially when you have multiple things on the go, no matter what the things are. When you have multiple things on the go, that way you can kind of keep yourself you know, focused for what is the meat, and then the potatoes come after, right?
Right.
You made mention too, and please forgive my lack of knowledge on this, but you made mention of binders, of study binders, and that intrigues me because that's paper-based format, and I know that with the qualitative research studies that I've been part of, we save everything's online now. So I wondered if there was any you know, any insight you could share on that, on the binders and how those are kept organized. I have so many questions.
Yeah, well, I think one of the reasons why we have both paper source documents for our patients and electronic is because here in Interior Health, patients' charts are still a combination of paper and electronic records. And historically, we had binders with what we call wedding signatures. So your clinical trial agreement with Health Canada is a wedding document. Other things like that, your contract with your sponsor. So there's a lot of documents that, yeah, over time, they may very well all transition to electronic documents. But right now, we have a combination. So that's when I say binders. A lot of our studies still have regulatory documents in binders, and our patients, like the signed consent form, the forms that I print off so Dr. Takash can acknowledge that he's seen them and is in agreement with what I have been charting and entering into the database. So that's all part of, we talk about GCP, good clinical practice. There's also GDP, good documentation practice. So you have to do all of that, and you have to have evidence that you have done that. So that's why we still have paper charts, paper binders, or clinical report forms for our source documents.
Makes good sense. And I'm noting the time. We have 1 minute until conclusion. So I have one final question for you, Marie, which is, what would you say to someone looking to join and become a clinical trial coordinator?
Do it. We need more people. It's a very satisfying occupation. Well, I love nursing. I never stopped being a nurse as far as I'm concerned. But the nice thing about being a clinical research coordinator is you get to spend more time with your patients. And that's become a real issue for a lot of nurses because we're short-staffed and we have to rush from one task to the next. It's difficult to find that time to sit down and talk with your patient and just hear their story. And I think that's one of the reasons why patients enjoy being part of a clinical trial, is they have somebody who can hear their story and advocate for them. And that, for me, that is the most rewarding thing about my job is the patient contact. I like helping people.
I think that's the perfect way to wrap up this session presentation. Thank you so much, Marie, for your presentation today. Thank you everyone so much for joining. We appreciate your time.